For those of you joining us today for Food Systems Friday, we'll give you a little bit longer to have other folks join us. A lot of our participants start logging into Zoom at the top of the hour, so we're a minute or two early. And so I wanted to point out something new. If you're a repeat viewer of Food Systems Friday, we have some QR codes now. So if your phone is enabled, please feel free to point your phone in that direction, and that will carry you to specific websites. So that's the landing page for Food Systems Friday in case you missed previous episodes, and we go from there. So I do want to be very transparent. We're waiting for our guest today, and so we'll give her just a couple minutes. She's participating in the Obesity Society's conference today also, and is looking forward to joining us. So while we are anticipating her arrival, I just wanted to go ahead and introduce myself and those of us who are here today. So my name is Robin Curry, and I am the director of the Master of Science in Sustainable Food Systems program. And that's an online program. It's an intentionally online program because we really want students to be taking what they're learning in the classrooms and applying all of that knowledge to transforming their food systems to be more sustainable in their own communities. So we launched the Food Systems Fridays to support all of you and your communities as you work to transform food systems. We focus here on policies and practices and people who can show us and help us learn about models of sustainable food systems and communities, such as our guest. So we are hoping she will join us shortly. We're looking forward to welcoming Dr. Fatima Cody Stanford. And as an ethnoecologist, I was really pleased to learn that her bachelor's degree is in anthropology, so right up my alley. But she comes to us, and again, I have the QR code there if you would like to be able to learn more about her specific background. And I just got a note that she will be here at 8 minutes after the hour. So I apologize for the delay, but I hope that you will stay with us, and we have plenty of things to talk about in the meantime. So if you would like to, how about we go ahead and I'll introduce my colleague here. This is Dr. Wendy Sue Harper has also joined us today, and she will be monitoring in the chat. And so if you turn your attention to the chat, Dr. Harper is going to go ahead and paste Dr. Fatima Cody Stanford's bio into the chat so that you have the opportunity to learn a little bit more about her. But you're also welcome to just point your code or your device in the direction of that QR code, and that will link you directly to her website. And so Dr. Fatima Cody Stanford is one of the first fellowship trained obesity medicine physicians in the United States, also a scientist, an educator, and policymaker. And she has dual appointments at the Massachusetts General Hospital and also at the Harvard Medical School. So she specializes, as I mentioned, in obesity medicine, and she bridges the intersection of medicine, public policy, and disparities. And so I want to point out, her credentials there. So MD, Master's in Public Health, Master's in Public Administration, and I understand that she's also currently working on her MBA, work in progress. In 2 weeks, we will be here airing on our next topic. So if you've registered for this webinar, you will automatically get an invitation and the links. And so while we're waiting for Dr. Stanford, I do want to let you know that the webinar is being recorded, and we do make these webinars available for free via our website for folks who are unable to attend. So please do understand that when you participate in the chat, you are agreeing to allow Prescott College to distribute that chat. Usually we go ahead and post the Zoom and recording and also the chat, because all of you are such wonderful resources for one another about the issues that our guests are speaking about. So we really do appreciate the ability to do this, to share the recording for those of you who aren't able to be here in real time. So please, I invite everybody who has joined us today to please say hello, provide a brief introduction in the chat, let us know where you are tuning in from, and feel free to say a few words about why you're here today, because that can help us learn about organizations that all of you are engaged in and the issues that those organizations are concerned about. Let's see. Other moments here is I do want to point out that we have two different ways for you to pose questions to Dr. Stanford. So one is in the Q&A section. So if you hover your mouse at the bottom of your Zoom screen, you'll see that little Q&A area. And so you're welcome to click on that and pose your questions, but you're also welcome to pose your questions in the chat. Dr. Harper will be monitoring it, as will I. And so we'll be able to field questions and put those to Dr. Stanford. So she should be joining us in just a couple more minutes. I wanted to share part of why I invited Dr. Stanford, and I've been working hard to have her engaged in Food Systems Fridays for a number of months, actually, because I had the good fortune of tuning into a webinar that the Resilient Sisterhood put out about food systems and racial bias in the time of COVID. And Dr. Fatima Cody Stanford was one of the speakers at that time, which was how I was introduced to her work. And what I really appreciated about her work is that it resonated very much with courses that we offer here at Prescott College. So at Prescott College, in our Health and Human Development program, we offer courses. One of them is called Fat Bodies, Stories of Grief and Transitions. And another one of the courses offered by my colleague is Disordered Eating, Body Image, and Culture. And what we know, and one of the things that we're concerned about in terms of food systems study, is that we do have pretty serious biases against those with obesity, and those biases against those with obesities can be particularly acute for when combined with racial biases. And a lot of the challenges with obesity are not as we generally frame them in terms of an individual behavior issue, and that paradigm needs to shift. In food system studies, we look at the whole structure of the food system and how the structure of the food systems creates barriers. If we frame it in a different way, that it creates barriers for us to be able to it creates barriers for us to be able to be healthy, as many of us who spend so many hours on Zoom these days start to understand. Dr. Fatima Cody Stanford should be joining us any second now, and I really appreciate some of the invitation or introductions that. Oh, yay! Seeing some friends and colleagues who are joining us today. I would invite the rest of you to please continue with your introductions, and we're looking forward to Dr. Stanford joining us in a moment. In the meanwhile, I'd like to go ahead and make another announcement of some of the food systems activities that are going on with Prescott College. And so I'd like to ask my colleague, Dr. Harper, to pop into the chat the link to a podcast that the Sustainable Food Systems program here at Prescott College also produces. And that podcast is called The Capstone is what it's called, and it focuses on current scholarship and current research that faculty and students here at Prescott College are engaged in. And so I invite you all to pop on to the Capstone, www.thecapstone.info, and this should provide some more information for you and opportunity to listen in on what some of the most recent scholarship is. So I think the episode that we released this week was Chad Snader, who was working on developing a business plan for a food truck in his more rural area as a way to help make more local food available in his communities. So I see that Dr. Fatima Stanford has joined us. And so we're very pleased that you are here. I'm going to stop sharing my screen and hand the mic over to you. I've already introduced you to all of our viewers, and they're excited that you could join us today.
I'm happy to join. It won't let me, it says host disabled participant screen sharing, so it won't let me share.
I will fix that in just one moment. And I'm going to need to ask for help from you, Carla, to make sure that.
I think it's working now. I think we're here. I think we're here.
Wonderful.
All
Excellent.
Right. So everyone, thank you so much. This is like presentation number 3 for me today. I have one more after this will end tonight for me. I'm delight for me to be here with you. And today we're going to be talking about the role of weight and race bias in health outcomes. And thanks so much, Robin. I'm sure you did a lovely introduction. So thanks so much for having me today. So we have a few objectives that we want to cover, and that's to discern how weight bias and stigma contribute to energy storage. We'll learn about how early life interactions actually influence weight bias. We'll determine the deleterious impact of weight bias on health outcomes. We'll ascertain how health professionals actually harbor both implicit and explicit weight bias. And we'll evaluate how organized medicine organizations have sought to really address the issue of weight bias. Now, when we talk about weight and how we talk about it here in the United States, it's defined by looking at body mass index. And there are some flaws with looking at just measurements. These measurements don't give us a lot of information about the context of whether this is fat, adipose, which is an organ, whether it's water, whatever it might be. But with that being said, this is how we define obesity in adults. So let's look at this BMI category. So persons who are considered to have underweight, a BMI of less than 18.5, normal weight status, a BMI of 18.5 to 24.9. Those that have overweight, a BMI of 25 to 29.9. And then we get into these 3 classes of obesity: mild, moderate, and severe, class 1, class 2, and class 3. A BMI of 30 to 34.9 being mild obesity. Someone that has moderate obesity has a BMI of 35 to 39.9. And those with severe obesity, a BMI of greater than or equal to 40. Now, notice you should listen to the language that I'm utilizing. I have not called a person obese. I want you to delete that word from your vocabulary. These patients have the disease of obesity, and I'll teach you a bit about that in just a moment. So we really want to take away stigmatizing language. Now, what I'm going to show you, I know that you guys are over there in Arizona. Arizona is getting a lot of attention right now. But what I want to talk about is this self-reported obesity. So if patients were, or persons were asked, and of course, for me, I think in terms of patients, what they feel they fall into the category. And the reason why this is important that I'm really denoting this is based on what we call the BRFSS, which is the behavioral risk factor surveillance system, is that it's self-reported. And so we often know that we might underreport our weight. So this is probably not getting to, really the actual levels, but you can take a look at you guys over here in Arizona. I'm obviously based here in Massachusetts. And what I want you to see here is that I want you to look at the different categories. So less than 20% prevalence of obesity. You don't see that anywhere on the map back in 2011. When we're looking at those that have between 20 and 25%. This is in the population. You can see that in green. Arizona gets picked up here between 25 and less than 30%. And then we start getting into kind of crimsoning of the map. I'm at Harvard, so we like to talk about crimsoning, but in this situation, it's not a good thing, okay? So you can see orange, 30 to 35%, and then greater than or equal to 35% is that crimson. So I just want to take you from 2011 to 2015 and just show you how quickly this map changes. So you're going to see kind of an animation that pops up here. And you'll see pretty quickly how, actually it takes you to 2017, how quickly this map changes, okay? You also may know we're in 2020, in case you guys didn't know that this was 2020. But this is the most recent data coming out of the CDC. So I want you to take a look, remember that map that we looked at before, which was 2011, 2017. Arizona looks similar, but you start seeing this crimsoning of the map, a little bit more predominantly in the Southeast, but we also have West Virginia and Iowa that come into play here. And only a few really kind of green standouts: Colorado, DC, Hawaii. Self-report data still. So I want us to pay attention to that. Now, when we look at this map, looking at non-Hispanic white adults, I want to take a peek and look at how this map looks. And we're going to compare and contrast this to the major racial ethnic groups here in the United States and see some differences that exist. So here you see West Virginia being picked up in 2017 as persons having a higher prevalence of obesity. Arizona still in that yellow color, if you guys are continuing to look over there, which is fine. And that's important. So I just want you to kind of store this in your memory. Think about this, because we're going to look next at Hispanic individuals. And this is the map for Hispanic adults here in the United States till 2017. And we want to look at their map and compare and contrast to what you might remember as the map we just looked at for those that are white adults here in the United States. You see a difference here in Arizona, for example. We start seeing crimsoning of the map. You also see quite a bit being picked up in Texas, Oklahoma, Kansas, South and North Dakota, Illinois, Michigan, for example. I'm glad I remember all of the states. That's a good thing, right? I think we've been all looking at the map quite a bit also most recently. All right, so that's Hispanic adults. But what really brought me to this work as a Black woman in this field is the next map. And this is non-Hispanic Black adults by state and territory here in the United States. And I want you to take a pause and look at this map and look at the differences that exist. If we're looking at BMI, I don't think we like to live in Idaho, Montana, or South Dakota. So that's one note there. But what I want you to see is the really relative, complete crimsoning of the map that exists. Arizona per se is not, is in that color just right before the crimson. But what you see is, even where I am in Massachusetts, my home state of Georgia, being a product of the Atlanta public school systems, I like to look and see and compare and contrast. And so this is important. We need to look at some of the disparities that exist. But what brought me to this work was looking at the prevalence of overweight and obesity in Black women particularly. So what we do know is that 60% of Black women have obesity, another 20% have overweight, which means 80% of Black women in the United States have overweight and obesity. And I think there are multiple reasons as to why this is. And so my goal is to figure out what this is and how do we go and address this issue. So I'm going to teach you guys a little bit about obesity, hopefully more than you've been able to learn previously, and really change the scenario, the thought process we think about overweight and obesity. So what you've typically learned, I can't go turn that off now because I would move my whole screen. So that's you may hear a few chimes, is energy balance is pretty simple. Okay. So we think it's all about calories in, our food and beverage intake. We're Food Systems Friday. So, we're thinking about food and beverage intake, right? And calories out, our bodily functions, our physical activity. And if we can just get this under wraps, then we should be fine, right? But what I'm here to tell you is that is indeed false. Energy balance is not that simple. So we're going to learn about the complexity of energy balance. And hopefully that'll help gauge how we think about those individuals that are in our families, ourselves, even that struggle with overweight and obesity, that it's not all our fault. Okay. And that's really what I want to get across here. So it's important for me to let you know that obesity is indeed a multifactorial disorder where genetics, environment, development, and behavior all play a role in a person's likelihood of having this disorder. And I'm going to get a little scientific for you. Don't worry, I'll bring it back down after this. So just hold on for about 2 slides, okay? So the organ that's extremely important, actually the most important in regulating one's food intake is actually the brain. And it's not the brain that you actively tell yourself, I'm not going to eat X, Y, or Z. It's actually telling you what to do. So if I were to take your brain and kind of just slice it in the middle, kind of slice it down that part you see in my head, we would get to a portion of the brain called the hypothalamus. You don't have to remember this, but what is important to know is that the hypothalamus is getting signals from your fat tissue, your large intestine, your small intestine, your pancreas, and your stomach, and is sending signals back via these 2 nerves, the spinal and vagus nerves, to tell you not only how much to eat, but actually how much to store. So when people say, I just walked past that donut shop and I feel like I gained 5 pounds, there's some slight validity to that. Their body decides to store much more than someone else's. Doesn't mean they're better or worse than anyone else. It just means their brains work differently. Now we're going to kind of think about that, and I'm going to break it down, right? Because I don't want to go too far down that pathway. So we get the brain, right? So we have the brain, and the brain is getting signals about our diet quality. We wanted to have lean proteins, whole grains, fruits, and vegetables as our predominant source, but it's important to recognize that just because your diet looks like that does not mean that you'll be lean. You may still have obesity, still have severe obesity because your brain has decided to defend a set point. I like for people to think of it as like a car. And I know we don't think of our bodies as a car, but let's think about it. If a person has severe obesity, their car may be more like an army tank, and their brain is going to do whatever it can to defend a weight in that army tank range. There may be someone really lean or little, like a Kevin Hart. I don't know why I just thought of him, but let's just use him. He's a tiny kind of human. I've seen him in real life. And his brain is like a smart car, like one of those little smart cars. And he really can't get up to another level, right? I think that's why they compare and contrast like The Rock, right, to Kevin Hart, because there is such huge differences between their just body habitus, but neither one could be the other. And so I just want you to think about how the brain is super powerful in defending that set point. Now, physical activity is extremely important when we look at weight and weight regulation, but what we as doctors typically sell to you guys is absolutely incorrect. We say, go to the gym to lose weight or go work out to lose weight. And on average, when we look at physical activity and the role it plays in weight regulation is it causes weight stability. And so this idea that for many people that we're going to just drop dramatic weight by just exercising is indeed a fallacy. So I want us to get out of that thought process. Now, physical activity is great for a lot of things. It's great for improving stress, reducing disease risks, and things of that sort. But for obesity in and of itself, or weight in and of itself, it typically creates stability. Sleep quality and duration does play a role in how the body regulates weight. So we want to be thoughtful about our sleep quality and duration, which is important. Medications that we as doctors prescribe can cause significant weight shifts. And I usually kind of go through a laundry list when I'm talking directly with patients. And you may kind of listen to this list and think if you've ever been on these a month or longer. So lithium, Depakote, Tegretol, Celexa, Cymbalta, Effexor, Paxil, Prozac, Ambien, Trazodone, Lunesta, Gabapentin, Glyburide, Glipizide, Glimepiride, long-term insulin, long-term prednisone, atenolol, metoprolol, propanolol, and IVF medications, just to name a few. Some of these medications can cause upwards of 80, 100 pounds of weight gain. So it's important for us to recognize that. Now, this looks like another sleeping person, and indeed it is, but I want you to see that this person is now sleeping during the daytime. When you're sleeping during the daytime, that is off of our circadian rhythm. So as humans, we're supposed to be awake when it's bright outside and sleep when it's dark outside. Our little furry friends, i.e. mice, rats, have a different sleep pattern. They're awake at night, sleep during the daytime. So we need to be following that natural rhythm. But for many of us, maybe we have jobs that don't allow us that opportunity. Maybe we're a doctor that works in the hospital in the middle of the night. Maybe we're someone that delivers food in the middle of the night. But when we switch that can cause major weight shifts. And then finally, thermogenesis, which is just how much the body burns at rest and with activity. This plays a large role in how the body regulates weight. And a lot of this is really genetically determined. So these are all some key factors. Now, this is one of my absolute favorite slides, and I want you guys to, take a look at this. I don't expect you to commit this to memory. I won't be offering any test questions on this, but I do want to show you that these are all the contributors to obesity. And this really explains why that initial kind of balancing scale that I presented was indeed false, okay? There are many factors that are inside of an individual that lead to weight gain. There are factors that are outside of an individual. You can see here that these things increase one's intake, okay? And these things here at the bottom decrease how much you're able to burn. And then these things here in the middle, I want you to kind of pay attention here. It says intake and expenditure or unknown, meaning we have yet to figure out how some of these things work. Now, these colors on the slide actually mean something. It's not just to make the slide look pretty, which I think it does. These are contributors or influencers to overweight and obesity. And so I'm going to kind of blow those up on the next slide because I know it's pretty tiny, but you can see how many factors play a role. These are kind of the big categories. We have biological or medical reasons, food and beverage, behavior and environment, maternal and developmental, social, psychological, economic, and then environmental pressures on physical activity. Now, I'm just pulling out a few of these. You can see there was about 100 or so things in that particular diagram. So I'm just pulling out a few key representative ones so that you just get a sense of what was kind of found within the larger diagram. So things that might increase one's intake are hyperreactivity to environmental food cues. Like you pass by that pizza shop and you have to have that pizza. Like, wow, I need that. Delayed satiety, which means it takes you a long time to get full. You just have to continue eating a much larger portion maybe than someone else. Disordered eating, and a lot of people engage in disordered eating, especially when they've struggled with weight or have had weight struggles in their life. Things that may decrease how much you're able to burn are actually like the bacteria in your gut. So what we do know is that for people that have obesity versus those that are lean, that there are actually different types of bacteria in the gut. So much so that here at our hospital, we're doing experiments where we're taking the gut microbiota, which means stool, out of individuals that are lean and placing it in individuals that have obesity. And we're seeing weight shifts without making any other modifications. So that bacteria flora that's in the gut can have huge implications on your weight status. We talked about thermogenesis, which is how much your body burns with rest and activity in the last slide. So things like if it's low, it's going to decrease how much you're able to burn. If you have a physical disability, obviously you're not able to burn as much as someone that does not, or who's more able to do things. Things that may increase intake and decrease expenditure are genetic and epigenetic factors. And so it's important to note here that weight is more heritable than height. We often don't think about that. We think about, if you have tall parents, you're going to probably be tall. If you have short parents, you'll be short, which is height. What we don't know is that the heritability of overweight and obesity is on the order of 50 to 85%, no matter how optimally you feed them or whatever in terms of children once they get here. Age-related changes. These are particularly important in women's life. So there are 3 primary times during women's life based upon hormonal shifts where we may see major weight changes. At the onset of menses as an adolescent, if a woman decides to have children or if she gets pregnant, and then also menopause. Menopause is huge in terms of weight gain. We have a decline in estrogen, and we go from having a gynoid distribution of fat, which is fat stored in the kind of the hips and buttock region. And then we go to having an android distribution of fat, which is stored in the midsection. So android is not just a phone, it's actually male-like pattern of fat storage, which is in the abdominal region. Mood disturbances also can cause increased intake and decreased expenditure. These would be things like depression or anxiety. Things that are outside of an individual that may lead to obesity or environmental and chemical toxins, pervasive food advertising, larger portion sizes. Things that may decrease one's expenditure are the built environment, sedentary time, and labor-saving devices like if you put your clothes in the washing machine or something of the sort. Things that may increase intake and decrease expenditure are weight bias and stigma. And don't forget, I remember that we're talking about that, but I need to set you guys up for understanding why this is important. Weight cycling, mean if you gain and lose weight, every single time that you gain or go on something that can't be sustained over the life course, your brain will be very angry with you and will come and defend a set point that's even a smidge higher than where you initially started. And then maternal and paternal obesity, which gets into some of the genetic piece that we talked about. So let me take you to a story that makes me somewhat vulnerable talking about weight bias in my childhood. I want to point out this is me, taken from one of my classes. I think it was about 5 here. It says lean, mean dancing machine. I know you guys can't read that, but I thought it was it's cute looking back at it in my 40s. Here's my sister who turns 40 in just a few, my baby sister, she turns 40 in just a few weeks. And so I just wanted to put this here because I want to take you back to a conference I went to. Right now, we're in the middle of what's called Obesity Week, which is part of why I have so many talks. Obesity Week is put on by the Obesity Society, which is the largest international organization to study in overweight and obesity, both prevention and treatment. So I was at a conference, let's take us about 5 years ago, and a young woman who's also an obesity medicine physician came up to me and started speaking. I've known her since this time. So she took dance with me at Spelman College in Atlanta, where I grew up. And she comes up to me and, we've known each other obviously for many, many years. And she says, Fatima, I really want to talk to you. And I was like, okay. For what you guys don't know is that if we were in person, I have a lot of people that like to come and talk to me. So she had a hard time really kind of cornering me, even after she said, I want to talk to you. It took her about 30 more minutes to really get me by myself. So after a strong, valiant effort on her part, she gets me alone. And she says, I don't know if you notice that I've always been really, standoffish towards you. So no, I didn't really know that. I thought that was just her personality since I'd known her for 35 years or so. And she says, well, there's a reason for that. So I figured there was something to come after this. She said, well, when we were about 5, you came up to me in dance class and you told me that I was fat and you walked off. So like a dagger in my heart, I realized that she had been holding on to this, first of all, for 35 years. I had said this. And here I am supposed to be this obesity expert who talks about weight bias. And it was quite humbling. First of all, I felt really dismayed by the fact that I had caused this harm to this individual, and that she had held on to it for that long. But then I realized how words matter. I mean, not that I didn't realize that I said that then, but for her to come and harbor that really showed that this is something really important. So that shows that even, the experts in the world, we're not perfect. Obviously, no one's perfect, but it really brought home to me kind of what my history was in terms of thinking about this. Now, when we look at bias in Western societies, the 2 most common forms of bias, particularly here in the United States, in case you weren't aware, are race bias and then weight bias. So if you did a Google search as recently as 2016 for young Black teens, you were met with mugshots of young Black boys. If you did the same search for white teens, you were met with kind of smiling faces, and peer groups, you can see here with the football and a basketball, soccer. This was reported back in the Washington Post in 2016. When they ran this story, Google changed their algorithm so that it no longer immediately returned results that were all mugshots. So that's race bias. Now let's look at weight bias. Weight bias is indeed another form. It's a common thing that we do. We look at an individual, we determine their value or worth based upon their size. So when we look at someone that's lean, we may have these adjectives: vain, superficial, confident, mean, for example, as a way to describe that individual. And then we look at this woman who has obesity and she's lazy, giving, insecure, passive. Maybe she's nice. And we make these because these are the things that we have stored in our head about what these individuals must be like based upon how they look. Now, this overlay of race and weight bias is indeed disturbing, because when we look at race bias, a way of how we evaluate individuals, and then weight bias, you can imagine the collision of the 2 are indeed a poor combination. Let's talk about how early in life we began to see weight bias really come about. So in this particular study, they looked at moms and their children, a pair of 70 individuals. And what they found was that the older infants, so 11 months of age, actually had a bias towards looking at figures that have obesity. But by the time they were 32 months of age, you guys listen to that, 32 months of age, they actually preferred looking at an average size or leaner individual. This preference was directly correlated with their mother's anti-fat attitudes. So if the mom had attitudes and or beliefs, then they unfortunately conveyed that to their child. And when I give this talk to parents, they often come up to me and they're like, well, I don't say anything bad about, individuals that have obesity. Hopefully they have the right language. And I said, well, it's not just what you're saying, it's also what you're not saying. So let's say you're watching television with your child and you always comment on the lean individual, how attractive that person is, but you never say anything negative or otherwise about an individual that has obesity. The message that's being conveyed is that person is not as valued. My mom or dad doesn't think the same positive things about them because they'd never say anything. So it's also what's not being said. So I just want to make sure that that's conveyed. So, I don't want to let dads off the hook here. So there was another study that was conducted. This was actually done and published in the British Journal of Developmental Psychology, and they were looking at both parents. So they looked at a larger subset. The last slide, we looked at 70 individuals. This is looking at 279 individuals, and it was children, 3-year-old children and their parents. And parents had to complete a body size, attitude, and dieting measures questionnaire, and the children were actually interviewed. And what they found with the children was that over time, negative attitudes towards large bodies and awareness of weight loss strategies were really based upon what their parents were conveying to them. So these stereotypical body size attitudes were coming out very, very early in life, which explains why I set up that story for me at 5, how that was entrenched. I guess I'll blame my dad. I'm going to blame him most just because why not? Let's look at, does this matter? So does this matter in terms of health outcomes? Is this just like, okay, people should get over it? I'm going to say the answer is a resounding no. Weight teasing in adolescence actually has been shown to affect weight-related outcomes in adulthood. So in this particular study, this was a big study where they looked at about 1,800 individuals, and they studied them for 15 years prospectively. So if we started now and studied for the next 15 years to 2035. And they had a diverse cohort, and this was called the Project EAT, or Eating and Activity in Young Adults. What they found, however, was that weight-based teasing in adolescence actually predicted a higher BMI and obesity 15 years later. And they found that females were particularly affected by both peer-based and family-based teasing, while males were mostly affected just by their peers. And so what this is it leads to this vicious cycle where we have binge eating, leading to dieting, leading to unhealthy weight control, leading to body image issues, and then an increase in BMI. So this isn't just, people that internalize this weight bias, this actually affects their overall health. And when we look at this weight bias internalization, meaning you feel that bias, it actually leads to poor outcomes. So in this study, and that came out in Obesity, the journal Obesity, they looked at the blood pressure and waist circumference, blood sugar, and cholesterol measures in adults with obesity. And in this trial, this was actually predominantly Black and female. You can see they looked at 159 adults, and they gave them a weight bias internalization scale and questionnaire. 51 of those adults, so about a third of the individuals, met criteria for what's called metabolic syndrome, which means your body has a predisposition to developing type 2 diabetes, okay? And what they found was that if you had high weight bias internalizations, that greatly increased the odds of you developing metabolic syndrome, which is the precursor to type 2 diabetes, and high triglycerides, which is one of the bad cholesterols. And when we look at the mental health of persons with obesity who experience bias, there is physiologic stress that happens that leads to weight gain, which leads to disordered eating, which leads to maladaptive behavior. So it actually affects the mental health and the physical health of those that have obesity. Now, let's look at what happens to medical students. There was a study that was conducted of medical students from medical schools throughout the country, both public and private. And what they sought to do in this about 1800 group of medical students was study them from their first to the fourth year and see what kind of bias they had with regards to weight and weight status. So they used web-based surveys, they looked at weight bias, medical school experiences, and school climate. And what I want to show you is what we see here. Now, implicit bias is what you will see here. Implicit bias is that bias that we don't really know that we have. It's just internal to us. And so they compared the general public, which is in this dark line, against the changes study. The changes studies are the medical students that were in this particular study. And so this looks good, right? So over time, you can see that the public has an increase in implicit bias in terms of weight status. And the medical students seem to have a decrease, which is great. That's their implicit bias. That seems to be great. But let's not give them a gold star as of yet. Let's look at our next slide. When you look at explicit bias, which is that bias that we outwardly have, that we know that we have towards individuals that have weight struggles, you can see that for the general public, you know, it's relatively stable. I'd say 49.3 and 49.9 aren't significant, a little up here. But notice how for the medical students over their 4 years of medical school, as consistent increase. So they became worse in terms of their outward expression and beliefs towards individuals that have or with obesity. And I really just think that's a detriment to the care that we can provide to patients. If these are the people that become the doctors, then are they going to be doing a disservice to patients? And my answer would be yes, based upon this data. So these are some of the conclusions that came out of that study. Medical schools may reduce students' weight bias by increasing positive contact between students and patients with obesity. To eliminate unprofessional role modeling. So I might be behind closed doors and someone says something that's very deleterious or something I see is very biased, and I correct them and they're like, oh, it's just us. I don't care. You should be using the same language behind closed doors that you're using in front, you know, if we're doing a presentation. And so that's extremely important. And I call those people that are even senior to me on that. So they know, I think they are scared to do it in front of me now. We don't alter the curricula to focus on treating quote unquote difficult patients. This is the conclusion. I didn't like this conclusion, but I wanted to bring it out here because are these difficult patients? So even in their attempt to address weight bias, they're calling them difficult. So you can see how there are issues there. Now, I really want to, you know, spend just a little bit of time on this slide because I want to show you kind of the complexity of weight stigma and the treatment of obesity. So what happens is weight stigma actually leads to stress. That actually changes eating and physical activity behavior. So we see binge eating, increased caloric consumption, maladaptive weight control, disordered eating, lower motivation for exercise, and then less physical activity. That then leads to also physiologic reactivity. So if we were to actually measure things in the doctor's office, we see increased levels of cortisol, which is a stress hormone, C-reactive protein, another stress hormone, A1C, which is your average blood sugar, and then elevated blood pressure. What happens is that affects healthcare service access. So poor treatment adherence, they don't trust us as health providers, they avoid follow-up care, and there's a delay in preventive health screenings and poor communication. That then leads to weight gain, which then causes psychological health and distress, where we see depression, anxiety, low self-esteem, poor body image, substance abuse, and suicidality. That again leads to physiologic health and distress, where we see poor glycemic control, which is that blood sugar control, less effective chronic disease self-management, and more advanced and poorly controlled chronic disease, along with lower health-related quality of life. So towards this end, what I've really been a huge advocate of is changing some of how we as physicians consider this idea of weight stigma. So here in Massachusetts, Massachusetts Medical Society is the oldest individual or state-based society in the country. I wrote a bill about preventing weight bias, or what we call it, a bill within our house, our body of house, here at the Massachusetts, to really look at weight stigma. And what you can see here is that these are some of the key things that came out of this report that I wrote that passed the House of Delegates back in 2016. It says the Massachusetts Medical Society recognizes that weight stigma in the healthcare setting leads to disparities of care and poor health outcomes in patients with obesity. The HP means health policy, so it's a health policy. The Massachusetts Medical Society will develop and promote educational information to physicians and physicians in training about weight stigma. That's a directive that we're telling the Mass Medical Society they have to do. And that the Mass Medical Society will advocate for legislative policies and institutional practices to prevent weight stigma. So that was great. That was on the state-based level, but why stop there? As the chair of the Minority Affairs section for the AMA, I've been active and involved with AMA for almost 18 years now. And I thought that it was important for us to utilize what we had done at the state level and really kind of look at what we could do at the national level. So I helped get this particular as a resolution passed in the House of Delegates in 2017, which looks at people first language in obesity. And so it says our AMA, which is the American Medical Association, encourages the use of people first language, patients with obesity, patients affected by obesities in all discussions, resolutions, and reports regarding obesity, encourages the use of preferential terms in discussions and reports regarding patients affected by obesity, which include weight, unhealthy weight, and discouraging the use of stigmatizing terms like obese, morbidly obese, and fat, and to educate healthcare providers on the importance of people first language for treating patients with obesity, equipping their healthcare facilities with proper size furniture, medical equipment, and gowns for patients with obesity, and having patients weighed respectfully. So I'm going to summarize, and then we're going to open up, I guess, Robin, for questions. Weight stigma does have a negative impact on the health and psychological health of patients who struggle with obesity. However, weight bias is seen as early as infancy, and it's really up to us, the parents, the grandparents, the godparents, the aunts, uncles, to really think about how we may be playing a role. The maternal and paternal anti-fat bias that exists really influences children. So it's important for us to recognize parents in their roles. That weight bias may be mitigated by proper training in health professionals. Here is a book that I wrote that comes out of Mass General Hospital, which is where I am on faculty. It's called Facing Overweight and Obesity, a complete guide for children and adults. You can see my name on the front here, and it came out in conjunction with two of my psychiatry colleagues, looking at the complex interplay of obesity as a medical disorder, but also the role it plays in mental health, which we've explored today. This is available if you are a Kindle Unlimited subscriber. It's free. If you're not, then it's on Amazon for purchase. And it does include quite a bit of information for both children and adults who have overweight and obesity, or if you want to support someone in your family or as a friend that may have this disease process. I do want to thank you so much for your time. Here is my contact, my social handles, etc. It has been a delight to be with you, albeit late because of my other talks. And it's just, I'm hoping to open this up for, questions that you might have that I can hopefully entertain. So thank you so much for your time.
Yes, thank you so much, Dr. Stanford. I think everybody's heads are probably spinning with all of the excellent information you shared.
It's a lot. See, that's why you guys needed to be, you need to kind of relax. That's why I was a little late. So I just need you to kind of relax, and then we bring you in, and here we are. So.
I love it. Well, what you're getting in the chat is, lots of thank you so much. Some requests about being able to access the slides because they really appreciated the framing.
Oh, absolutely.
Yeah, great, wonderful.
I'll send you the PDF, Robin, when we hang up, so that you can share. You can share with whomever wants it.
Wonderful. Thank you so much. I think I haven't seen any specific questions in there. Like I said, I think folks are still formulating, but I'm going to take like director's privilege here.
Okay, go for it, Robin. I'm ready.
I've got one. I'm just curious about, food system studies, and we tend to have a lot of folks who are on the ground working in food systems issues. They're very complicated, and there are lots of other governing bodies involved in all of the issues surrounding supporting those with obesity. Absolutely. And so, I wondered if you could share with our listeners, your opinions about some of the other governing bodies that, we could help support the effort around weight destigmatization. Who could we be targeting for policy reform?
Oh, absolutely. So I would say number one off the top of my head is a group called the OAC. OAC stands for Obesity Action Coalition. So this is a group mostly made up of patients. So when I say mostly, 99% of the people that are members are patients that have obesity. There are
Mhm.
75,000 of them that
Woo.
support each other surrounding overweight and obesity, seek evidence-based, so you guys saw me presenting study after study after study. I don't say thing if it's not a study. I'm a physician scientist, so a lot of the studies, I'm obviously publishing, not all, there's hundreds and hundreds of, papers coming out every day, so I can't quite go at that speed, but like to contribute to this body of knowledge. The Obesity Action Coalition is advocating specifically for one particular bill that is before both the House and Senate that has made it every single session in the last 4 or 5 years. Has been going before the House and the Senate. It's called the TROA Act. TROA stands for the Treat and Reduce Obesity Act. It is getting bipartisan support because obviously we know that obesity, and despite what's going on in our country, is not a partisan issue. But the issue is that I think it needs to attach to maybe a larger omnibus bill. So I'm putting on my political hat here, the Kennedy School hat, where it's kind of must pass legislation. What we know that this particular bill is supposed to do is, number one, provide better access to care for work with dietitians.
Mhm.
So right now in the United States, work with dietitians is not covered unless you have a diagnosis of diabetes.
Yeah.
So we wait for you to get diabetes, then we give you access to a
Right.
dietitian. But what about getting you prior to that time? I would think that, that would make sense. But right now, there's not appropriate coverage. So the Treat and Reduce Obesity Act includes that as one of the key issues: access to behavioral and lifestyle modification therapy, particularly with work with people like dietitians whose work is not often covered.
Mhm.
The number two thing that it covers, and the second and final thing, is that it covers access to medications for the treatment of obesity. So
Mhm.
it's important to note a few key things. Robin, is number one, only 2% of patients that meet criteria for the use of what we call anti-obesity medications in the United States get access,
That's
which is
concerning.
quite I would say that's a little low, you guys, 2 out of 100,
Really?
and so that's problematic. I think a lot of it has to do with poor education of physicians, some stigma. There's a lot of different factors that may play a role, but also coverage by insurance companies. So we'll cover diabetes medications, we'll cover hypertension, we'll cover all these other things, but we often don't cover the drugs that treat the disease, where we can get rid of all the other diseases. So that's another consideration. So they have been the strongest advocate in the group, in addition to groups like the Obesity Society, who I told you our meeting is going
Mhm.
on this week. And so a lot of these groups come together, the Obesity Medicine Association. But I would say that the group that stands out most vividly as really the strongest advocates for looking at weight bias stigma, looking at legislation, hands down, is the OAC, a group that really has wonderful patients, some of my patients. I don't know which of my patients are members, but just, I like to speak to the group because I like to hear what they have to say, and also listen to what they're able to teach me. As someone that doesn't have obesity, I have to learn from individuals that have this disease. Yes, I'm the expert, right? Like I can do the medicine, I know how to do the things, but I have to hear what's being said for me to even think of like what the next research question is, something that may not have been investigated. So hopefully that gives some information to you, Robin, that will be helpful in thinking about partnering. But the
Yeah.
OAC is a really great group.
Yeah, thank you. Extremely helpful. And that also gave some folks the opportunity to get another question in. And so one of the questions is from Carly, and she's wondering how to have conversations with teenagers who struggle with obesity.
So this is a good question. I think it depends on the context in which you approach it or how you approach it. Sometimes adolescents or even children. So I see kids as early as the age of 2, and my oldest patients are in their late 80s, like 88, 89. And when I have kids coming into me, I ask them, what do they feel about their weight? You want to kind of start with that. How do you feel? They may not feel anything. And you can ask, have you ever been teased about your weight? And how have your doctors been able to help you? Sometimes I told you we're some of the worst people in the room. We're the ones that tell you you did something wrong. You come back and you did something wrong. You didn't do something well enough. If that's indeed the case, you want to make sure that you align them with someone like myself, wherever you are in the country, that is trained to treat patients that have obesity. And a way to know who that is, Carly, is the American Board of Obesity Medicine has persons that are board certified like myself in obesity medicine. And you can actually go and search on their site by zip code and by state where people are. It'll tell you what their backgrounds are. So for someone like me who takes care of adults and children, I would be an appropriate person, obviously, for a teen, but there may be internists who only treat adults and they're like, I don't want to see anyone that's below the age of 20. So, you can kind of sort through there. But I think it's really having an open conversation, not being accusatory, not saying something they've done wrong. As teens, we already don't like to be told that we're wrong. We think we're grown, we're not. And so you want to invite a conversation. I hope that helps, kind of you as you're thinking about how you, work with teens or adolescents that have obesity.
Yeah, thank you. This is actually a little bit of a related question.
Okay.
So this is coming from Adrian, and she asks, understanding the complexity of all the factors shared, do clinicians believe that they need to, quote unquote, cure folks experiencing obesity?
Do they need to listen to them? Is that what she's saying?
No, I think it's well, yeah, maybe that's part of it. Yeah. So, the part of it is like I'm paraphrasing and please feel free to pop in the chat if I didn't paraphrase correctly here. But do they need to cure folks experiencing obesity?
Oh, so you don't really cure. So you never cure. So obesity is a relapsing, remitting, chronic, progressive disease. So even if I send someone to surgery, I'm still taking care of them for life. They may have a lesser degree of weight, and maybe their weight has normalized. And I'm putting that in quotes because that's different for every person. My patients can tell you I never give them a weight they need to be. I don't give them, they need to be this BMI. Because everybody's body responds differently to different treatment modalities. So, coming back to the question, and hopefully I'm answering this well because I'm not 100% sure I completely get it, but I think that physicians need to be better aware of obesity as a disease, better equipped to treat it so that we can have a downstream impact on other disease processes. So where I get my gratification with this work, in addition to the weight response that patients get, I would say that I'm much more excited when I'm able to remove diagnoses from their medical chart. And there's sometimes I'm removing all of them and I have nothing left to bill for, but thankfully they have a code for history of something. So I have patients where they've gotten rid of their obesity. So I have to say history of obesity. They had high blood pressure, history of hypertension, history of obstructive sleep apnea, history of diabetes. So I love taking things off the list. I mean, it's great, but then and it makes my note very easy to write. So it's great all around. Patient wins, I win. It's a great thing. So it's a chronic disease. Even when patients, do resolve, many of their things, what we're doing is we're fighting the body's change. So those hormones that we didn't really go into a lot of detail about, they have a propensity to want to rear their ugly head. So let's say if someone some to bariatric surgery, which is the gold standard for the treatment of severe obesity, yes, they lose acutely. I call that the honeymoon phase. You guys know if you got married, that first year or two is fabulous. I'm about 20 years down, maybe not as fabulous, but anyway. So in that you come down, and then your brain starts to come back, meaning those hormones that kind of were optimized immediately after surgery are no longer optimal. And so when you see people regain, whether it's surgery or medicines or just diet and lifestyle modifications or behavioral therapy, it's those hormones that are saying, nope, it's a tug of war, and they're pulling you back the other direction. So I never get rid of those patients because the brain always wants to do that, no matter. And some brains want to do it a little bit more than others, but they still want to do it. So I'm always treating them. So you can't cure it. I wish I could. I'd win some Nobel Prize, and that'd be delightful. But it's right. It's so complex and so multifactorial that I don't think we'll ever have really a cure. I just think we'll have better treatments.
Yeah. No, thank you. There's one more question, but I want to do a quick time check with you. Do you have time
I'm
for
fine.
one
I'm
more?
fine. I'm fine.
Wonderful, thank you.
Yeah.
And so this question is, what is known about how negative health outcomes related to weight bias break down by race?
Oh, that's an extremely great question. I don't think we have that data. So ooh, that sounds like another study for me, but I have 20 going on, so I don't know, but I'll think about it. I don't think we have a breakdown really by race. Now, there are some studies that have looked at like Black individuals, for example, more like by themselves as opposed to as like in a like a breakout per se, where you're looking at several different groups. So if you look at the Jackson Heart Study, which comes out of Jackson, Mississippi, you do see that individuals that are, let's say, Black, experience significant weight bias, and when you couple that with what they feel they expect, receive in terms of racism, that leads to poor health outcomes. And actually, in that particular study, the Jackson Heart Study, you when they measure stress hormones like cortisol, CRP, the things that we've talked about a little earlier, when they actually experience that racism, that really drives up those hormones and causes more deposition or storage of adipose, which is the fat, the organ. And so when we talk about the complexities of things that lead to, and I think this does, I don't think it's the only thing that explains the disparity in obesity rates here in the country. But experiencing racism is one factor that plays a large role and how we look at weight and storage and genetic and epigenetic changes. And epigenetic, just to let you guys know, is me passing through generations.
Mhm.
So if generations have experienced something negative, that continues, can even skip a generation. And the way to kind of explain this from kind of like a medical standpoint is that if you're a woman, okay, your mother gave birth to you, right? You had all of the eggs that you needed while you were being developed, which means whatever your grandmother was experienced, that child that comes out of the mom is directly related to what they now experience. So it's amazing how this intergenerational transmission of things like obesity occurs, and it seems to be much more pronounced in individuals that have been subject to stress over time, stress in the form of racism and other inequities. So hopefully that answers it. I would say that there's not a really great study that delineates side by side comparisons, but I can tell you that we've seen it individually pulled out, much like we've seen in the Jackson Heart Study, which is one of the largest studies done on Black individuals here in the United States.
Thank you. It looks like we all have more work to do. And
Yeah, we do. This is a life's calling. The reason why I take as many talks as I can is I want to explain to as many people what I do know. And you can begin posing these questions, and maybe you do the research also. We want to see you guys contributing to the literature, and I can present that paper at the next talk. But this disease affects 42.4% of U.S. adults based upon 2018 data. Keeping in mind it's 2020, and a lot has changed in terms of just our life and how we conduct our lives every day. And probably I would presume that the obesity rates continue to climb. This is not going anywhere anytime soon, but we need to have as many thought leaders on the ground, and we need to have as many people working in the communities to do the work. Robin, like you mentioned earlier, who's on the ground? We know that I didn't really talk about this, and I guess we talked about lean proteins, whole grains, fruits, and vegetables. We want less processed food. And what we've seen in COVID are two different things that have borne out, right? We've seen actually a few things. COVID and obesity are directly related. So if one has obesity, there's a greater likelihood of morbidity, sickness, and mortality, death, and that's regardless of race or ethnicity, and also regardless of age. So we've seen that just kind of play out consistently with the over 230,000 individuals that have died in this country alone. We've also seen this collision of looking at issues like disparities in race, right? We've seen that COVID-19 appears to directly impact more communities of color. I think this is related to a variety of reasons as to why we've seen that borne out. One of the lectures that I gave earlier this week was on just COVID-19, or what we call the title that I had was The Color of COVID. And I was looking at COVID-19 in terms of racial ethnic disparities, but also in the context of weight status. And what I'm seeing from patients is patients are more ready to accept, treatment of their obesity, looking at the bad prognosis they've heard in the context of COVID. So I think that, there's so much to be done. There's so much that yet to be discovered, but that we do have a lot of tools that are going unutilized or underutilized as with regards to treating patients that struggle with this chronic disease. And I think that's where we're failing. It's not the stuff we don't know. Obviously, if we don't know, we can't solve it. But there are things that we do know, and there are tools that we do have that we're just not utilizing to help our patients and help your family members, help your friends, your colleagues. And so that's where my work comes in also.
Mhm. Yeah, well, thank you very much. I think, I can speak for myself, but we really appreciated the opportunity to learn more from you. Just we're all coming from different aspects in the
Right.
food system, and we need, access to all the different areas of expertise. So thank you so much for sharing. And now people know who to call. Yeah.
Absolutely. You guys can go and, Robin, I thank you for having me speak in Arizona. It would be nice to actually be there. I don't think I've been to Arizona, which is a sad thing. I've heard it's gorgeous. But I will make sure, like I said, to have the PDF of these slides as soon as we hang up. I'll convert these to a PDF so that you can have them and you can look at the information that I provide.
Wonderful. Thank you so much. And thank you to all of you who joined us today to listen in live. And thank you to all those who I know access the recordings. So may everybody have a safe weekend and, have some time to percolate and marinate on all the things that Dr. Stanford shared with us. And we'll get the slides out in our distribution list when we receive them. So thank you so much. Best of luck on the rest of your talks and closing out Obesity Week.
Obesity Week. It'll be a great closeout. So I think so. We have the last talk of the whole week, so we'll see.
Wonderful. Well, thank you so much. So
have a good day.
thank you. You too.
Bye-bye.
Bye.